wonderful opportunity, anything with this cultural training series. And then Chris Sams will also be the administrative support for the Intertribal Council of Michigan. Next slide, please. So I thought this poem is a good way to kind of kick us off. It comes from John Fox. He is a poetry therapist. And it's called When Someone Deeply Listens to You. When someone deeply listens to you, it's as if it is like holding out a dented cup you've had since childhood and watching it fill up with cold, fresh water. When it balances on the top of the brim, you are understood. And when it overflows and touches your skin, you are loved. When someone deeply listens to you, the room where you stay starts a new life, and the place where you wrote your first poem begins to glow in your mind's eye. It is as if gold has been discovered. When someone deeply listens to you, your bare feet are on the earth, and a beloved land that seemed distant is now at home within you. Next slide, please. So our learning objectives for the Hope Cultural Training are listed here. I'm not going to read through all of them. I'm just going to kind of briefly summarize because we are going to drop into the chat a document that contains these 5 Hope Cultural Training objectives. And it also contains how to get your CEs. And it also gives you our disclosures because the 4 of us have nothing to disclose financially. So we are going to talk about cancer disparities. We're going to look at factors that contribute to those disparities in Native Americans. We're going to look at some of the lived experiences and hear from Native Americans during our cultural training and discuss ways that we can better build trust in our clinical encounters. And then we do have a component of learning about patient-centered outcomes research and comparative effectiveness research so that we can look for and explore ways that Native Americans perhaps would like to collaborate with us, any of us in this group, or within our state, or those of you outside of your state, you also could apply some of these principles to engagement exercises there. Next slide, please. And then today, we're specifically just talking about the Native American barrier, some of the barriers to cancer care in rural Michigan and developing a broad understanding of this HOPE project in our cultural training series and how to access our growing garden resources. And Catherine's responsible for some of the creative ways that we're going to continue to learn outside of these sessions. And we're also going to learn how to access the PCORI resources and the patient-centered outcomes research and comparative effectiveness research site. And next slide. I think it's turned over to you, Beth. Thank you.
Go ahead, Laura.
Hi, good afternoon, everybody. I'm going to talk about some of the cancer disparities in the Native populations first within the state of Michigan. So our population in Michigan is 90% greater risk of lung cancer with a 40% greater risk of dying. Native women are at higher odds of advanced breast cancer diagnoses and lowest survival rates for nearly all types of cancer. In Michigan, patients that are tribal referred to non-tribal health systems up to 500 miles from home. And models of cancer care exclude integration of cultural norms and considerations of traditional healing, meaning they need to take into consideration more of their traditional ways. Next slide, please. So today we're going to discuss the tribes and the tribal populations in the state of Michigan. So in Michigan, we have 12 federally recognized tribes, and then we have our urban location, the American Indian Health and Family Services. So there is 6 in the Upper Peninsula, 7 in the Lower Peninsula, plus the American Indian Health and Family Services. Next slide. So one of the really cool things about the state of Michigan is that the tribes and the tribal populations, not meaning all tribal members living in the state of Michigan, but all tribes, federally recognized tribes, are a part of the Anishinaabe Nation, Anishinaabe people. And I wanted to break down what this is because that's very unique and that doesn't always happen within states. There's a lot of different tribal populations that are all interdispersed throughout different states, but Michigan is very unique and it has all Anishinaabe populations. And that covers the Chippewa, Odawa, Potawatomi, Algonquin Sioux, Mississauga, and Ojibwe up in Canada. That's the Métis people are part of the Anishinaabe Nation. And I wanted to share this picture because Anishinaabe Nation is huge. I don't know if a lot of people have researched down south with the Navajo Nation, but we're almost just as large as that is. And we originated coming from the coast and moving over, and a lot of our stories are oral tradition, and that's where um, a lot of our migration type stories come from as our oral traditions. But Anishinaabe means you're going to get a lot of different interpretations of what the word Anishinaabe means, but some say it means original people. Other groups say it means people live on the earth the correct way, good humans. Um, there's all different types of interpretations depending on who you're talking with. So I don't want to ever just like say Anishinaabe people means original people because you're not going to hear that. You're going to hear many different variations of that. Basil Johnson, he's a really amazing traditional writer. I would recommend reading his books if you guys are very interested in our culture and our traditions and our sacred stories. He says that Anishinaabe translates to beings made out of nothing. And that kind of goes back to our origin stories. Um, Next slide, please. So I just listed a bunch of that belong to Anishinaabe Nation, but the ones that are located in the state of Michigan, they really refer to them as the Council of the Three Fires. And we are Ojibwe or Chippewa, you'll hear within different naming categories. Odawa, Ottawa, you'll also hear in the Potawatomi. Ojibwe, they say keepers of faith. They also, another thing you'll hear is keepers of traditions. So a lot of the storytellers are Ojibwe. Odawa, keepers of trade, and Potawatomi, keepers of fire. And this is like, they're very proud of those titles. We're very proud of what we carry and what we work together with. And we wanted to highlight that here. And those are a lot of the tribal communities. So we have a lot of different Potawatomi communities. We have a lot of Ojibwe and Odawa communities that are located all throughout the state of Michigan. And they're interdispersed all over. You'll also find them within different states, Ojibwe, Odawa, and Potawatomi, and also all throughout First Nations communities over in Canada. Next slide, please.
I was just going to pause for 1 second. Does anyone have any questions on these slides that we've covered so far? Please feel free to put it in the chat or unmute yourself for a second.
And I think while we take this pause, I will send out our first poll. You can go ahead and take a moment to respond to that.
You can go to the next slide now, Beth.
Okay. Hi. Okay. Hi. Hi, everyone. So I really think this map talks about the reality of life for rural Anishinaabe and also rural Michiganders, right? Studies, including both rural and urban American Indian cancer survivors, reveal that the barriers to receipt of optimum cancer care and symptom management is proportionately lower, right, among American Indian and Alaska Native populations. These circles depict the general area of the tribal communities, the Indian reservations in Michigan, and also the tribal service areas. When we talk about a tribal service area, this is the either a 3-county or 5-county area, some 6 or 8-county areas where Indian healthcare is provided to tribal members. So if you have a tribal membership in Sault Ste. Marie for the Sioux Tribe of Chippewa Indians, and you live in their 5-county tribal service area, your primary care can be delivered at no cost to you. And however, that's primary care. If you need cancer care, you will have to travel either to Petoskey, Ann Arbor, Detroit, or Grand Rapids, which is a minimum of 2-hour traveling distance. Additionally, if you live in the Upper Peninsula of Michigan, at the last count, there was 1 palliative care provider. And Sault Ste. Marie has had struggles with hospice, right? Hospice home care and hospice in facility care. So this you can see the depth of cancer mortality and how it relates to the location of our tribal communities. So I'm going to give you a very condensed version of healthcare for Native Americans. The Snyder Act of 1924 provided legislative authority for Congress to appropriate funds for Indian health, but that didn't go under the Indian Health Service. Indian health care was managed by the Department of Interior, and everyone knows the responsibilities of the Department of Interior, and is that really an appropriate place for healthcare? But in 1924, it should also be recognized that that was the year Native Americans were deemed to be U.S. citizens. Prior to then, they were not U.S. citizens. And so it's really important to understand that the people who first walked our land were not considered citizens until about 100 years and 6 months ago. So something to ponder when you consider the duration of disparities and the challenges that our Anishinaabe face in the state of Michigan. The Indian Healthcare Improvement Act became the legal authority for healthcare for American Indians and Alaska Natives. That was enacted in 1976. And that basically established like national policy for Indian health under the IHS. Like GIPRA measures similar to HEDIS and CMS. That's where they began this journey with establishing guidelines and goals for care. Although GIPRA didn't come until later, it's the same concept of measure. The Indian Healthcare Improvement Act ensured tribal rights to access, bill, and be reimbursed for federal programs. So there were tribal health systems prior to 1976, and they were delivering care to their patients, but they weren't being reimbursed. So if a patient was Medicaid or Medicare, they were not being reimbursed for providing that care. They were sustaining their own health system with limited federal funds to support that health system. They couldn't even build, so there used to be an old program called CHAMPUS for military retirees, now called TRICARE. And they would provide care to their citizens. And if the citizen had gone to any other provider, that provider could have billed for care, but the tribal clinic could not. And it wasn't until this was enacted in 1976 that happened. Additionally, this expired in 2000, and it sat out there until the Affordable Care Act came into play, And when the Affordable Care Act was established, they permanently reauthorized the Indian Healthcare Improvement Act. And this ensures that tribal clinics have the same authority as other federally qualified health centers, that they can bill for seeing their patients, whether it's Medicare, Medicaid. Our tribal clinics can bill for federal programs like BCCCNP, all these breast and cervical navigation programs. So they are, in essence, a federally qualified health center, and they are all grandfathered that status in the state of Michigan. And if you're wondering what 638 is, so 638 is the bill that authorized self-governance and operational control with federal funding for tribal facilities. So previously, IHS oversaw all health systems that were supported in tribal nations. And under 638, the tribes can self-govern their health system. They can identify the coverage area in the patient service area. They can identify their operating hours, how they're going to run their practices. So it's truly giving them back their sovereign rights to operate the health system that best serves the people of their communities. This quote, I think, is very poignant. American Indians and Alaska Natives have the first world's prepaid health system, and we paid for it with our lives, our land, and our way of life. And that's a quote from Kathy Abramson. I'm going to introduce Kathy. So this is Kathy Abramson. She was born a member of the Sioux tribe of Chippewa Indians at one time, and she served on the Sault Ste. Marie tribe of Chippewa Indians Board of Directors. She was the chairperson for the National Indian Health Board. She was a recipient of the Jake White Crow Award. She was Indian Health Service Director Special Recognition Award for Tribal Leadership and Partnership in 2013. And she was the first female chair of the Human Services Secretary Tribal Advisory Council. So she had a very big influence on improving the health of Native Americans across the US and Alaska Natives. And a lot of her programs were mirrored by Canada and First Nations organizations. Kathy Abramson did a lot to advocate for the health and wellness of Native Americans. And her husband, who is a retired nurse practitioner, are going to tell us their story and their journey.
My name's Kathy Abramson. My family, we have deep roots in this area of Bawatine, Sault Ste. Marie.
My name's Tony Abramson. Kathy and I have been married for 45 years. We call this our home in Sault Ste. Marie. Love our home.
2011, found out that I had cancer.
She was diagnosed with an abnormal mammogram, then was sent to get a needle biopsy.
If I didn't have my husband helping me out, I probably would have been gone a long time ago. And my family, my kids, my grandkids, I've been spoiled. I don't take that for granted at all.
She had a lumpectomy, at first chemo, then radiation, and then continued follow-up. I honestly don't know how someone with no background really deals with that, because it's just so much. Just getting the diagnosis of cancer puts you in a spiral in which I don't think you hear half of the stuff you're hearing when you hear it. So having somebody, some family member, somebody knowledgeable in that area to hear all that information is absolutely essential, because I don't think people would remember managing all the information was probably one of the most difficult things, taking it from place to place so that wherever Kathy had to go, we had all that information. Transportation is a difficulty. I mean, it really is a challenge. If you look at rural America, I mean, you can't have everything in this community. So you have to almost plan to go 300 miles one way to Ann Arbor. We traveled. Geez, we did that weekly when Kathy was really being followed up close. It's a long way.
I'm just enjoying being alive. And that's why it's important for people to take care of their health. You have to go to those mammograms because that's how I found out. You can live so much longer if you catch things in the beginning. You should take a look at their pictures of their families that they need to be around for. I've seen a lot more things go on in the years that I've had.
Time is precious. Get the most out of it. There's things you can do, simple things you can do. I know tribal members love and care for their families and their communities and their people because we've experienced it. I mean, we see it every day, how much they love each other and how much they love Kathy and our families.
Just enjoy life, stay calm and just think of all the good things, because there's a lot of good things.
I want to thank Kathy Abramson for sharing her story. And I hope that this story gives you the opportunity to think about how your organization or you as a person can support rural Native Americans and citizens across the state of Michigan in finding equitable opportunities for care.
Thank you, Beth. That was such a beautiful story, and that's the second time I saw it, and it's so powerful. I think hearing people's stories, and I'm so thankful for Kathy and for Laura, for carrying on the traditions after your mother. So thank you for that. Okay, so we're going to talk just briefly about the Hope Project. And so this session, if you're joining today and you're like, okay, this is not at all what I expected, please come back because this is not a traditional like how it's going to be. But we were so afraid. We have so many cool speakers, and we were so afraid of bringing in one of our keynote speakers and then having to cover some of the administrative things to just tell you about the project, which we have to do because of our what our obligation to our funder. And we want to do, but we didn't want to take away from our other speakers. So today we're going to talk just briefly about the Hope Project. So this is a 2-year award. Like I said, we're prioritizing listening and trust building. And the first year, so in year 1, you can see on the graph, we have a little orange box that's called Hope Cultural Training. Anyone can come to this. So if you have people that you're thinking, man, I think some people would benefit in my organization, please share that with them. It's not too late. They don't have to come to every series. It's like anyone can come. Then the Hope GONAs, GONA stands for Gathering of Native Americans. And it's a framework, it's culturally based process where community members can gather and address issues in a culturally appropriate way. There's a navigator, there's a person who is the facilitator of that. They're trained. Laura is a trained facilitator, but we are having a trained facilitator, Don Lyons, who will be working with our GONAs. And so there will be specific tribes that have agreed to share their stories, and those will be going on in year 1. And then in year 2, there'll be a smaller group of individuals like representatives from organizations that will come into the Hope Learning Collaborative along with the Native American stakeholders who have participated in GONAs, and they will share their experiences with the collaborative, and together in a trusting manner after we've done our our research and we've gained more knowledge and we know how to listen better, we'll enter into this Hope Learning Collaborative space where in year 2, where we'll start to figure out how can we better support our Native Americans. And then at the end of that year, we're having a state GONA, and that's represented in the orange or little box at the end. That's open for anybody as well. So if you want to participate in the state GONA, the Hope Cultural Training, those are open to stakeholders. It's just there are Native Americans only for the Hope GONAs, and then the Hope Learning Collaborative is a smaller group of people, a smaller space for us to discuss. After the award, so post-award, then there will be opportunity for you to become part of the Hope Consortium. So if your organization wants to be in on looking at those Native American cancer priorities that our Native American stakeholders have identified, if you want to see how you can support a project or even a research to address some of the priorities in PCOR SIR, that will be post-award. So learning, even if you don't want to do the research piece, I mean, there's all kinds of needs, that advocacy needs that we need to address. And so that will be coming after the 2-year award. Next slide, please. And then this slide is just showing you the PCOR SIR and what that stands for. So PCOR is patient-centered outcomes research, and SIR is comparative effectiveness research, where you would have 2 studies. Let's say you have a person that's depressed and you have an intervention that works for depression, like mindfulness, and then you have also an intervention that works for depression, cognitive behavioral therapy. You would do a study to compare both of those. So SIR is one type, and then patient-centered outcomes research is just looking at what's important to that patient. Both of them are patient-centered. That's the whole premise of the awards with PCORI. They want your patients and their families to be at the very center of what the research is. So there is some specific training, and we're going to drop the link into the chat. It's also on this slide. And when you go to that website, it will be a series of modules. And so you kind of go at your own pace. You do not have to participate in this if you do not want to. I mean, if you came just for the cultural training, that's fine. But the November and December presentations that we will do will be our group kind of discussing and brainstorming how we might come up with a PCOR or SIR study for Native Americans based on what we're learning in this series. And also, if you have attended the modules, will give you a better understanding and make you more prepared for those discussions. But again, that is, highly, up to you whether or not you participate. Those who are going into the learning collaborative, those individuals must they must go to the PCOR SIR training, and that again, it's you go at your own pace. They have a lot of really good interactive videos as well. And I, as a person who formerly taught research at a university level, I feel like I can also kind of navigate, and we have other researchers that can help navigate questions for those who are brand new to research. So you don't have to have a college degree. You don't have to have a lot of background in research. You can just show up and be part of this project. So are there any questions about that? Okay, you can go on to the next slide. I'm going to turn it over to you, Catherine.
Thank you, Cynthia. And I think at this time, I am going to issue our other polls. So, well, I will try to issue our other polls. If you would be so kind as to complete those, as Cynthia just wrapped up some of those questions that are relevant there. But my name is Catherine Williams, and as Beth, Laura, and Cynthia have talked about, this cultural training series is going to take place over the next several months, and we have an amazing set of speakers who are going to talk very specifically about topics that are relevant to this body of work and the engagement award that we've received. So on the screen here, you can see our schedule of presentations. Again, today is really an introduction to allow everybody who is registered as a participant the opportunity to learn more about the project, about the goals of this cultural training series, and then opportunities that you and your colleagues and peers may have to be more involved in this work. Next month, we will hear from one of our advisors on this project, Mary Isaacson, who's also on this call. I want to thank Mary for joining us leading up to today and for today's session. And then throughout the rest of the year, we will have many more speakers to share on topics that they are experts in and will help provide access to understanding, knowledge, and opportunities for action. So if you can go to the next slide. Out of many of these discussions, we do really hope to create dialogue, to create a discussion, to listen, to learn, and to open up a space for questions to be asked. And we anticipate that a lot of folks from all over the state will have resources and ideas to share. So we're working on creating what we're calling the Growing Garden. This is a virtual space where seeds can be planted and roots can be developed to grow into opportunities. So as the year progresses, as we hear from our speakers, we plan to capture what is shared, whether that's resources, articles, tangible items, or ideas, questions that you all have. We will be capturing those in a digital space and documenting and collecting those throughout each session or the series of sessions, hoping to make this available for public access on the Intertribal Council of Michigan's website so that you can go back and watch these recordings, access links to knowledge articles or readings, things like that. So again, we are really looking forward to this being a very robust, dynamic dialogue throughout the next several months leading up to more work to happen at a statewide level. So right now, it looks like our polls are being answered. I'm going to launch our final poll. You can get used to polls being part of these series. It will be another way for us to take learning and understanding into each series that follows. I think with that, we can go on to the next slide. And to kind of wrap us up today, we will have some time for more questions, but I'd be remiss if we didn't revisit this slide in particular. For today's session and all future sessions, we are offering CME through the Corewell Health West CME office. I'm going to be dropping a document in the chat for you all to access a digital version that you can capture and download. But in order to claim CME through the Corewell Health West office, you do need to set up an account through Corewell Health West Cloud CME. There's a link on the screen. And again, I will be dropping a document in the chat that will give you that link. Once you have set up your account through the Cloud CME office, there are two ways that you can go about in retrieving your credit for the day. The first is the option to text the Cloud CME. So the instructions are on the screen right here. For today, you would be texting code 65975 to the 844 number that's on the screen. The other option that you have to claim your CME would be to scan the QR code. In order to scan the QR code, you do have to download the Cloud CME app through your phone. So that I can drop in the chat. Again, there are digital resources available through a PDF, but that is the instruction for Cloud CME. And I think at this time we'll open it up to questions in the chat, or if you have questions, feel free to raise your hand and we can unmute and go that way.
And we can also go back to any slide if you have a specific question on geographic locations or a specific question about tribal health. Please don't hesitate to ask and we can scroll back.
It does look like the third poll did not take, so I am relaunching it. Thank you for letting us know in the chat.
And again, does anyone have any questions?
I do see that we have a hand up, Beth. Mara, it looks like you have a question.
You're on mute.
Have issues when I'm hooked up to a screen. Okay. I just had a question. So I had put in the chat about the mortality rate. So I'm just curious, and I would just open this up generally speaking. So when we start talking about research, I put on my sort of epidemiology hat, which is where these conversations tend to start. So given that it looks like there's this suppression because of numbers for those that were following my chat and my comments in the chat, I'm just curious how would we be able to measure down the road if we're looking at research questions that may present a challenge, in part because how do we know how we're comparing with with either neighboring states or with the rest of the US in terms of like comparative populations? Just generally, if anyone has any comments.
So across the US, the data on survivorship.
And understanding, I guess typically you would start with like, if you are exploring like a pre-post study design where you would have a specific intervention in mind, those numbers would be your delta, right? That would be your change to determine any effectiveness.
Okay, so these numbers for the state of Michigan, these are specific to Michigan. The disparities tend to be duplicated across the Great Plains, over and across the US, especially for late stage diagnosis, stomach cancers, prostate cancers, lung cancers, because there are behavioral risk factors that also influence the cancer mortality rates. But the late stage diagnosis, as you know, when Native Americans were pushed onto reservations, these are very rural, austere, remote areas. The data suppression in Michigan, I can talk to the fact that we haven't had a BRFIS that specifically looked at American Indians and Alaska Native as a population since 2017. The state of Michigan identifies which priority population they're gonna address each time the BRFIS comes up. And while we have the funding to do it, Native Americans have not been specifically addressed in the state BRFIS since 2017. Some of the work that could go on is what we call the tribal BRFIS, and where we actually have very specific questions that address the cultural norms of Native Americans in addition to the standard BRFIS questionnaire. So that's how we would do the comparisons, right? This map that you saw is the general BRFIS data, right? And cancer registry data. It is not specific to Native Americans, but you could see that where the reservations are located, where there are populations of Native Americans, there is also higher mortality rates and incident rates. Laura, did you want to say anything else on that?
No, I'm glad you covered the BRFIS. And that's across other states also. It's lack of correct numbers representing the populations that are missing, and that's where the BRFIS would really assist with this information to start research.
Because estimated there's probably only 2% of Native Americans are represented in the BRFIS data.
Could you share, Beth, just a little with the group about how, I know you've shared this with me in the past, but like how laborious it is to go through like the records to add and correct the missing data that is there? Can you just tell the group some of the work you've done? And perhaps there are people, I always thought of like medical students or somebody who would really, that would be a great project, but you need people to do that sort of thing.
So that has to be done. So the state cancer registry is a directorate under MDHHS, and is their staff and staff from the CDC that update and make corrections to the state cancer registry, because there is numerous errors in race data, right? I mean, that was truly highlighted for the general population during the COVID pandemic. But it has been systemically a problem for years, since they stood up the Vital Records Division in the States. So there are experts at the CDC who actually support states in addressing the cancer registry, and they will actually travel. I have not done it myself. It was done by our staff in the past. They actually travel to the tribes. They look at the state cancer registry. They go through the names on the registry. There are folks sequestered in a room, and they go line by line and identify if that last name matches a name on the tribal registry. The tribal registry folks are in the room along with the CDC rep, the state rep, and it's a very private thing. It's not a big room of folks. It respects individuals' privacy, their sovereignty, and their right to be identified as who they are, correct? And so when they do that, update the cancer registry, they validate whether that person was Native American or Alaska Native, or if the race is correct or incorrect on their birth or on their death record. And then if it's wrong on the death record, they'll also go back and update, make sure that the birth records are correct too. That's a very condensed version of updating the cancer registry. It could, but yeah, it's a big project. And we were beginning that a few years back, but then pandemic and staff changes, but there are experts at CDC, and this is what they do. They go state to state and sit with the state vital record staff and the tribes to ensure that everyone is appropriately represented, both in their birth and when they walk on.
Thank you. There was a comment in the chat. Could you, I don't know if we addressed the question, but could you go back to, it said, could you go back to the mortality slide? Could we go to the slide that shows these mortality rates?
We could, but I will.
And then I also have a question for those of you in the room. I used to be Zoom savvy, but then when I switched over to Teams, I am not Zoom savvy at all. And I think some of us are struggling with that. But like, I don't know how to add the attachment that I told you I was going to add. It's not, I don't, if anyone can tell me how to do that. Yeah.
Adding the attachment to what, Cynthia?
So I
This is
want to
Esther.
add it to the chat. Like I just want to add an attachment, like a document that shows you our objectives and gives you like the, you know, how to do your CE, you know, CME.
Okay.
Yeah, so click on that. Open the chat.
Okay.
Too involved, I guess you could say.
But he has them.
Like,
We don't need him to be involved. We need him to
Actually-
be on study and to be able to do a physical.
And then
Kate, we might. What's the turnaround
when you
time
click on that chat
for, we just
to open it,
had
if you there's like a
30 weeks, it'd
T
be,
with a pencil in the bottom left-hand corner of the chat.
Yep.
And then there is a, I think if you
I just put
drag
this
and
on,
drop,
they
that
didn't-
might work. Otherwise, there is the option to add a link. I don't know if you can actually
Yeah, I would just.
add a whole document.
Mail it out
Cynthia,
to y'all.
adding that
You
link
can always
probably would be
email it.
helpful. Up in the corner of where you were sharing your screen just a second ago,
Mm-hmm.
up in the right-hand corner, there's a share button,
Yeah.
Yeah.
and then it gives you the option to copy the link.
It'd be a lot more flexible than AJ.
But if it's a link that goes to to our organization, everybody won't be able to access it.
You got
You might
I'm
need to just
trying
email
We
it
can
then.
email it to everyone. We can email it.
We'll
to everyone.
email it to all of you. I'm so sorry.
Okay, are there any questions on this slide?
Sorry. I mapped out the whole cycle.
So were there any questions on when we bring up this is the overall cancer mortality in Michigan? Nope.
Okay.
There was a statement in here. Hannah, is that how you say your name?
Yeah, that's how you say my name.
Okay, sorry, don't want to mess it up. She said, "Thank you for sharing this valuable information. Much of what was discussed resonates deeply, especially the history surrounding the 1924 Indian Health Insurance Act. Crucial aspect of history that must be considered when establishing patient-centered care. With that in mind, how can healthcare institutions address historical mistrust when engaging with tribal communities in oncology care while ensuring patient-centered approaches that respect Indigenous perspectives?" I wanted to make sure that this one was highlighted. We agree with you, and that through this series that we have going on, these topics are all going to be covered, especially through the historical pieces that are going to be talked about, of actually timeline of what has happened in history and ways in which you could really work with the tribal populations on different topics, especially oncology care. Do you, Beth or Cynthia or Catherine, have anything to add to that question?
Yeah, I think we have this really unique opportunity. Like Laura said, each and every one of the speakers that we're bringing to you is going to give you the insight and the knowledge on how to provide the type of care necessary and acknowledge the needs of these patients. But most importantly, when the GONAs, these listening sessions, we're actually going to document the needs, right? And then share back with you all, right? Specifically what they need, whether it's they live in the UP or they live in northern lower Michigan, or we may have participants who live in other areas of Michigan. It's they're going to share their stories, and based on what they share, you're going to be able to understand what your organization can do differently, or what you as a person, how you can listen differently, how you can incorporate traditional culture or honor the spiritual practices of each individual, just like you would honor the spiritual practices of the individuals you serve now.
Thank you so much
That's
for
a beautiful
answering.
question.
Thank you for
Um,
asking.
I just also wanted to ask, will like that information of like more workshops that you guys will be having sent out specifically, along with all the attachments? Okay,
Yep. Each
thank you.
each month we'll update the invitation with any pre-reads that we may have available for you. And then when we stand up the Growing Garden on the ITC webpage, you will have access to that. We will have that link available in every invitation and in the chat of every all the following cultural training sessions.
Okay, awesome. Thank you.
Mara, do you still have a question?
Yeah, I think I know we're almost at time here, but I was just curious, I mean, just for the sake of discussion, this map, and obviously Michigan is quite a large land mass. How would you qualify briefly what are homogeneous needs amongst groups versus like the heterogeneity of the groups? In that there will be common needs and then there will be unique needs, I would imagine.
Yeah, and I think we have I mean, I don't know if Beth, if you want to address that, but what comes to mind is just some of the researchers who have looked at just rural. I don't know if this is getting to your answer or the answer to your question, but like the rural needs versus whether it's rural everybody need or rural Native American. Is that kind of what you're getting to, like uncovering the layers of what it is, Mara?
Yeah, I think there's just maybe how can I say the simplified first pass is that these are all the same, but they're not. So they will have very distinct, there'll be distinctions between groups. And I was just curious that I know Beth mentioned like there's some lifestyle habits, right, that would preclude them to being high risk, irrespective of their ethnic, racial grouping. But what, you know, how much of it is unique to that particular tribe or geographical location? That's a really big question, but just as a just throwing it out there.
Here's something to think about. So I'm just going to give an example.